Introduce Dr. Hilary Wang. I don't know if you all can see Hilary there. Hopefully you can see her. Hilary is, just a little bit about her background. She attended Harvard College, and then she went on to get her medical degree at Yale, as well as her MBA. Not sure how you did that, Hilary. How do you do an MBA and an MD at the same time? But that's pretty amazing. She then went on to do her neurology residency at Stanford, and having just completed that, has come to join us. Hilary has interest in quality and will be joining our quality efforts at Swedish and is a member of our neurohospitalist team. So she just started. I want to just a warm welcome to Hilary, and if you see her, you now have a name and a face. Please say hello. All right.
Hi.
The second new doc we've got is Dr. Kester Phillips. Dr. Phillips is one of our new neuro-oncologists who is joining Dr. John Henson. Dr. Henson's been holding down the fort, so I know he's super happy to see Dr. Phillips arrive. And a little bit about Kester's background. He attended the University of Southern Indiana, went on to receive his MD at Ross University School of Medicine. He went on to do his neurology residency at State University New York Medical Center, and then completed a neuro-oncology fellowship at Beth Israel Deaconess, as well as another portion at the University of Virginia Medical Center. Kester was working at Inova Fairfax Hospital before coming out west to join us here. And one thing I found out about Kester is he is going to be the recipient of the University of Southern Indiana Alumni Achievement Award coming up here, which is really quite an honor and distinction. And we're super happy to have you join us, Kester, and just a warm welcome. Again, please say hello to Kester if you see him.
Thanks, Mike.
Yeah. Okay, so with that, I'm going to turn things over to Dr. Henson, who will introduce our speaker this morning.
Thanks, Mike. Good morning to everyone. It's a particular honor to introduce Dr. Santosh Caseri from down in Santa Monica. A few things of note. One is that it's always fun to introduce somebody that was one of your trainees, who particularly when they sort of go on to stand on your shoulders and far exceed your own accomplishments. And Santosh and I worked together back at Mass General in the day when I had fewer gray hairs, and he is now running the neuro-oncology program down at John Wayne Cancer Institute, where he has a fairly large program with several faculty members and has developed just a fabulous program there in neuro-oncology. Just so you understand how this works, on the West Coast in the Providence system, there are 3 neuro-oncology centers, of which Santosh runs one, the one in Santa Monica, and then Ricky Chen runs the program out of Portland. And then we have, of course, our program here at the Ivy Center. And Santosh and Ricky and I have started working quite closely together on a number of projects. Santosh has a lot of clinical trials ideas that he brings forward. And so we're collaborating on that. We're also launching a tele-neuro-oncology program. So Santosh will have most of California. Ricky will have a little bit of Southern Washington, and we'll do Alaska, Montana, and Texas, because we took Texas. So anyway, Santosh and I, once again, are getting to work together, and that's a lot of fun. He's got more accomplishments than I could spend the whole hour telling you what he's accomplished, 250 articles, that kind of thing. He is a fabulous person. We're tickled to have him speak to us about neuro-oncology. Santosh?
Thank you, John. I'm going to share my screen. Yeah. Amazing to work with John to continue to build the neuro-oncology capability throughout the system in Providence. Can you guys see my screen? Okay. So what I thought I would do is just talk about neuro-oncology, a little bit of background, and then talk about some of the problems in neuro-oncology and why and how we could probably move forward to make faster progress. And that's really through translational research. What I've learned is you need to, for a disease such as brain tumors, it's really a team effort. You need to collaborate with scientists, clinicians, and multiple institutions and certainly have patient involvement and engagement. The other thing I've focused on in the last few decades is that we need to develop better drugs, newer drugs. Oftentimes we just get drugs that are made for lung cancer, breast cancer, and try to incorporate them and use them in brain tumors, but we really need to have our own drugs. And the other thing is how to do trials faster. And that's actually what Providence is able to provide. If we can organize and collaborate, we can make a powerful network to be able to run clinical trials from phase 1 to phase 3, so we can accelerate the whole process of drug development. And that's really what I've been focused on in the past few decades. And obviously you need support from the institution as well as philanthropy to drive this. So brain tumors are, really a distinct specialty with, not only do we deal with primary brain tumors, metastasis, leptomeningeal disease, but we deal with all the neurological complications that we have in our patients, from seizures to cognitive dysfunction to bone health, muscle health. So it's really a challenging clinical practice, because we really have to help patients in multiple ways that are very challenging things to deal with, all the medical problems that these patients have. And again, you need a team to do that. Although primary brain tumors are low, 23,000 a year, as I mentioned, we deal with all the metastasis, or the neurological complications of cancer. So it's a large volume of patients that could potentially benefit from neuro-oncological evaluation and management. And again, this is just some boring statistics of the number of brain tumors in the United States. But if you look at the overall population, 200,000 to 300,000 newly diagnosed metastatic cancers in the U.S., and any person with any primary brain tumor, about 600,000 patients. So it is a large volume of patients that are managed by multiple specialties, from neurosurgery to medical oncology to neuro-oncology to neurologists and other specialists. So it's really, again, needs a team to make this work. There are different types of brain tumors. Meningioma is the most common, but it's benign. We mainly deal with gliomas, and in particular, high-grade gliomas that are the worst prognosis. And you can see this pie chart here that shows the distribution of tumor types. And again, most of the practice in neuro-oncology is really malignant types of brain tumors, as well as malignant tumors in meningiomas and pituitary tumors and rare tumors. And I'll show you examples of that later in the talk, of trials and treatment approaches for those as well. So what have we done in the last few decades in neuro-oncology? It's been for many decades, radiation and possibly chemo were helpful. And then when I started my fellowship training in neuro-oncology with Dr. Henson and others in Boston, this paper came out in 2005 that combining temozolomide with radiation and followed by adjuvant temozolomide resulted in improvement in survival. This was the first prospective paper in many decades that's shown a benefit in glioblastoma. So this was a big deal for us back then. And you can see the survival curves here, but what the value of adding temozolomide is, and you get a 2-month median survival improvement, which doesn't sound very impressive, but if you look at the 2-year survival, goes from 10% to over 25%. So doubling of the 2-year survival. So that's really significant benefit, but as you can imagine, most patients don't survive 5 years, so we still have a long way to go. But this is the first prospective study to show this. So this is really, when I started my career, this was really positive news and exciting at the time. There was also some other excitement in terms of biomarkers to predict who would respond better. And one of the big biomarkers is methylation of the MGMT promoter. And as you can see here, it does predict improved response and survival to that regimen I just mentioned. If you're unmethylated, you have a median survival of approximately 12 months, whereas methylated up to 18 months, a 6-month improvement in median survival. around the time that I started, and probably many years before, is the development of targeted therapy. So the scientists around the world understood signaling, what drives cancer growth, and the pharmaceutical industry and academic industries also developed new drugs. So the exciting aspect of thinking about how mutations in signaling might affect tumor growth and drug development in that area has really spawned on many, many generations of clinical trials in various cancers. And I'm sure you guys have all heard about the amazing progress in lung cancer, breast cancer, colon cancer, melanoma with the advent of drugs that target specific mutations. And so using that same approach of mutation and drug, we also jumped on that bandwagon. And over the years, we've tested many, many drugs in gliomas of various sorts. And for the most part, most of them have failed. And that's been a real downer, as you can imagine, the last decade or so. But at the same time, as shown on this slide, in my clinic and many clinics, and I'm sure John's clinic, there are patients who respond to targeted therapies. You can see here on the left, this patient responded to a EGFR inhibitor, okay? And then on the right, a VEGF inhibitor, showing a pretty dramatic response within a month. Before the advent of VEGF inhibitors or targeted therapies, you would never see these kinds of responses in brain tumors to a single agent drug. And this is the reason why Avastin was approved in 2009 for recurrent glioblastomas, because of this amazing imaging response as well as clinical response. But only 30% of patients actually respond. And when you look at the targeted literature data, it's usually less than 10% of patients respond with other drugs. And this is the reason the threshold of most of these drugs having a response is not very high. And that's why many of them are not approved in gliomas. But certainly some people respond, and that really underscores the heterogeneity of the disease that we deal with. If you understand the genomics, what drives the tumor, and you pick the right drug, you can get an amazing response. And that's shown by this New England Journal paper of a very genetically defined brain tumor. These are patients with tuberous sclerosis that have this subependymal giant cell astrocytoma. This mutation, TSC1/2, that causes tuberous sclerosis, these patients have upregulated mTOR signaling. And everolimus is an mTOR inhibitor developed to block that signaling. And when you treat these patients with this mTOR inhibitor, you see these amazing imaging responses as well as clinical improvement in various symptoms. And it's almost 100% of patients respond to this drug. This was a small phase 2 study of only 20-some patients, and the drug was FDA approved in 2012 based on this study. Again, a very genetically well-defined disease with a drug that targets that pathway, and the drug gets into the brain. And so you can see how personalized medicine can have this remarkable effect. But unfortunately, glioblastoma, the patients that we see in our clinic are genetically very heterogeneous. And that's shown in multiple publications in the Cancer Genome Atlas and other groups, showing, as you can see here in this plot of gene expression analysis, different groups of patients classified based on expression profiling. So proneural, neural, classical, and mesenchymal. So this is one of the reasons why we don't have 100% response ever in glioblastomas, because the disease is very heterogeneous at the genomic level, as well as multiple other levels that we can discuss later. That's one level of analysis, but our friends at Institute of Systems Biology, as well as other institutions, can take the same data and look at it in multiple different ways and come up with other predictors of survival. And so this is a very complex disease, and the new genomics and big data analysis are really providing newer insights than the simple analysis of even 5 years ago. So I think this is something that we need to incorporate in neuro-oncology, and we are incorporating in many aspects of medicine, is the advent of genomics and big data and other types of data, and how it can predict response or help us do better with treating our patients. So But there are some commonalities in these tumors, and one of them is angiogenesis. And when you look at a glioblastoma under the microscope, you see this tremendous hypervascular blood vessels, hyperproliferative blood vessels, and Avastin, bevacizumab, was developed to target VEGF and prevent growth of blood vessels or neoangiogenesis to the tumor. And this is what we see on imaging, and I showed an example earlier where before treatment you have this large necrotic tumor enhancing with tremendous edema. And when you give Avastin, you see this shrinkage of the lesion as well as reduction in edema. Again, only 30% of patients respond. We don't really still have a biomarker, a genomic biomarker of why patients respond. Clinically, we kind of can tell based on the amount of swelling the patient has. But it's really, again, a challenge to, even when we have a drug helping to identify good biomarkers of response so that we can do better prospective clinical trials. Not only that, the biology is very complex, and I'll highlight that with these cases that we published many years ago. Even when we treat a patient with a drug, the cancer may respond for some period of time, but then become resistant. And there are various ways cancers can become resistant. Example here in figure 1, you can see an enhancing tumor treated with Avastin, and you can see the enhancement essentially disappear. But then later on, after a few months, new enhancing lesions close to the original area pop up. And this is a progression, maybe a clone of cells that is VEGF resistant has now started to come back. In figure 2, you see the enhancing lesions shrink and then increase again. And there have been studies showing that besides VEGF, these tumors have many other angiogenic factors, and we can see dynamic upregulation of other angiogenic factors in these patients in the blood when we're treating patients. So that may be why this form of resistance is due to upregulation of other angiogenic factors. And then probably figure 3 is probably the most worrisome of disease resistance that we've seen, where the enhancing component essentially disappears on Avastin. Even the edema improves on Avastin. You just see some residual T2 flare, which is probably residual infiltrating glioma after giving Avastin. And then later on, though, you see continued T2 increase, even though there's no further enhancement. And several studies and groups have shown that when you biopsy these areas, these are infiltrating tumor cells. So when you take away the angiogenesis from the tumor learns how to adapt, and now it starts to infiltrate into the tumor, into the brain, and spread to other places. So this sort of series highlights the problems we have in neuro-oncology, because we can't easily go and biopsy and interrogate the brain and figure out what's happening in a dynamic way that's possible in lung cancer and other cancers where they've made a lot more progress, and how tumors change dynamically and how we can target it in a combinatorial fashion to get better outcomes. So that's highlights the heterogeneity of the disease, but we also have many other issues. Drug access to the tumor because of the blood-brain barrier. And the other big thing is the immunosuppressive microenvironment, the fact that we use steroids, which suppress the immune system, and then the fact that radiation and chemotherapy, while good now, can also cause problems later, including suppressing the immune system and potentially promoting a more aggressive recurrence based on multiple studies. And we also do need to do better in terms of drug development. So the idea of heterogeneity and understanding that when we do clinical trials is highlighted in this case. This is a glioblastoma patient I saw many years ago. Right frontal, had radiation, had surgery, radiation, chemotherapy, had 2 or 3 other recurrences, was on clinical trials, failed. And this is the days before Avastin when I was in Boston. And at the time, we didn't have any other options, so I gave off-label kinase inhibitor, Gleevec, and you can see the patient had this amazing partial response 1 month later. And this got into my head that, we really need to understand the genomics. We went back to his tumor, and in fact, he had PDGFR amplification. And there was a prior study of imatinib or Gleevec, and the study was negative. Only 4% of patients responded. When we went back to that data set, it turns out those responders had PDGFR amplification. And PDGFR amplification, as shown in this preclinical study, when you give nilotinib, it really potently suppresses tumors in a sub-Q model if the tumor line is amplified. And we did based on that data, that one patient, and based on the preclinical data, we started a clinical trial when I was in San Diego of using nilotinib, which is a second generation PDGFR inhibitor called Tasigna. We did a phase 2 study in patients with recurrent glioblastomas. And here's an example of one of our patients on the trial that had a partial response and sustained response for over 4 years on the clinical trial. The study did finish, and we are wrapping it up and writing the results of the study, but about 20 to 30% of patients actually responded and benefited in this clinical trial. There's other examples of precision medicine in neuro-oncology. This is an example in pediatric neuro-oncology in medulloblastoma, which is, again, a genetically heterogeneous disease, but there's one subtype that is driven by the hedgehog pathway, and Genentech developed a hedgehog inhibitor. And an example of a response shown in figure 1, you'll see this medulloblastoma that's metastatic detected on PET scan before treatment, and then within months, 2 months after therapy, you can see a dramatic shrinkage of the tumor. That really highlights the power of targeted therapy and precision medicine. However, a month later, the patient's tumor came back rapidly, and you can see in 1C that new PET lesions popped up. One of them was biopsied, and it showed a resistant mutation was selected in the hedgehog pathway during treatment. So these tumors, while we developed new drugs that could help, they could potentially also, the tumor becomes very smart and can figure out how to become resistant to these drugs. And so we unfortunately can't interrogate the brain as easily as the body in terms of getting tissue and looking at what's happening. But this is one of the reasons we are having difficulty in neuro-oncology. We see short-term responses without the long-term responses we need in order to get drugs approved. But we try our best, and I will show you 2 examples of dynamic changes in our patients. This is a 42-year-old gentleman who's unmethylated, so which means poor prognosis, less than 1 year survival. At the start of treatment, he had his standard radiation and chemotherapy. When he progressed, we took out the tumor again because it was in the same location. And on mutation profiling, we found an EGFR mutation and mTOR activation. So we started the patient on a combination of off-label Tarceva and Afinitor. And the patient actually was stable for quite a bit of time. And then the tumor started to grow again. We took it out again, and the EGFR mutation disappeared. This patient eventually, did other treatments, but eventually succumbed to the disease, but 3 years from diagnosis. So this kind of highlights that, even though we don't have many drugs out there that are approved, drugs that are on the market could potentially benefit patients. And but we just need to do a better job of understanding what the genetic mutations are and how we can utilize that. And also, as highlighted, the mutations can change over time, especially in the face of selective pressures like drug treatments. Here's another example of a 44-year-old gentleman, again, unmethylated, who had a left temporal glioblastoma that was radiated and given chemotherapy, progressed 7 months later. He was noted to have a BRAF mutation. So we treated the patient with a BRAF inhibitor and also chemotherapy, and this patient had over a 2-year survival. Again, better than expected based on his genomic profile. So the reality is we need to do better. These cases highlight the fact that this genomic information is important in terms of when we do clinical trials. Most of the trials that we've done to date on targeted therapies haven't really selected patients for the most part. And we just need to do a better job at doing that. And the only way to really do it is in a multi-center fashion, because we don't have enough patients at a single center site to be able to do it quickly enough to answer the question fast enough to decide whether we should continue or not. And so having this sort of design of multiple arms for each subtype of tumors is very important, and having collaborations in multiple centers to do these trials is very important. And even in the immunotherapy field arena, we're also thinking the same way, that we need to do a better job of precision immunotherapy by selecting patients based on biomarkers. So what about the blood-brain barrier? I'll go through this very quickly, but for many years, we've treated patients with brain cancers of all sorts, and I learned this from a lung cancer patient where we gave gefitinib, which was one of the first generation EGFR inhibitors. This patient had lung cancer. We didn't know he had brain mets at the time, complete response in the lung, and then developed neurological symptoms. And as shown on the MRI, you see multiple leptomeningeal and parenchymal mets. So the simple reasoning was that, maybe enough and the drug dosing was enough at 500 milligrams daily, but it wasn't enough to get into the CSF. And when we checked the CSF level, it was low. So we simply increased the dose of gefitinib, and we got improved CSF drug levels. Cytology turned positive to negative, and patient clinically improved again for some period of time. And then eventually the tumor did become resistant and the patient did die. But this kind of highlights the need for at least CSF or tissue interrogation when we do drug development. Otherwise, we don't really quite understand how much drug got in and whether the tumor changed. And this harkens back to the days of using high-dose methotrexate. When we use normal dose methotrexate for lymphoma in the body, it's fine, but if it's in the brain, it doesn't really work. And we learned how to use high-dose methotrexate and provide supportive care along with that in order to get amazing responses in the field of primary CNS lymphoma, where patients used to die within 1 year, but now live over 5 years regularly. And that's really because we learned how to get drug into the brain in a tolerable way. And so that's what's been happening the last 5-10 years. New drug development has also focused on re-engineering old drugs, as well as making new drugs that get through the blood-brain barrier. This is an example of Taxol. This is a company that made a Taxol conjugated to a peptide that gets it across the blood-brain barrier. And as you can see in the early clinical trial that we did, some of the patients had some remarkable responses. And the drug is still being pursued in larger studies currently. But this is an old drug that's reformulated to get across the blood-brain barrier. I'll skip this one. We're also, there's a lot of innovation in devices, and many of you might have heard about this company called Novocure, the Optune device. We participated in the phase 3 clinical trial where patients wear this device that's shown in the upper left figure 24/7. It's alternating electrical fields, and this modality can damage DNA in multiple ways and inhibit cell division, as shown in many preclinical models. And to our surprise, to many people's surprise, it actually had a positive improvement in survival when added to temozolomide after radiation. And that's shown in this figure here, where the 2-year survival went from 31% to 43%, and with the continued tail at 5 years out. So this is one of the new devices that's approved in neuro-oncology in the last 5 years as well. So what about the immune system, especially in the last 5-10 years? I think everyone's heard about immunotherapy and the potential value of checkpoint inhibitors and boosting the immune system to kill cancers of all sorts. One of the challenges in our field is as I'll show you, boosting the immune system in the brain causes tremendous neurological side effects. And so we have to be careful at how we do this. And we have tried this over the decade with various approaches, including antibodies to various pro-inflammatory or tumor microenvironment negative states with VEGF, EGF, et cetera, as well as with peptide vaccines, oncolytic viruses, and small molecule drugs that modulate the tumor microenvironment, as well as more recently checkpoint inhibitors and cellular therapies such as CAR T cells, where we engineer T cells to go attack specific antigens. So far, we've tried all of them. One of the challenges is that we need to do complete removal of the tumor so the patients don't have swelling and don't need steroids, because steroids are anti-inflammatory and will affect any immunotherapy approach. And then also some of these approaches like checkpoint inhibitors can create a tremendous inflammation in the brain, which as neurologists, we know what that causes, including seizures, headaches, and worsening neurological symptoms. So the balance of stimulating the immune system in the right way without causing toxicity is an important challenge that I think we're still trying to figure out how to do that better. But there are examples of responses in the literature and I think many of our practices. And I'm cheating here because I'm using primary CNS lymphoma as a disease rather than glioblastoma, but nonetheless, it makes a point that even in highly resistant CNS lymphoma that's failed transplant, numerous chemotherapy, whole brain radiation, we gave nivolumab, a PD-1 inhibitor, and because otherwise it was going to be hospice at the time. And this patient actually responded dramatically within a month and continues to sustain a response 5 years later. So this shows you the value without brain side effects, although the patient did have immune side effects with arthritis and systemic side effects, but was in the brain-wise actually had a remarkable response without any neurological side effects. Shows you that this example shows you that we can do better even in brain tumors. Now that is Chemo, but that's CNS lymphoma. There have been some cases published in the literature of glioblastoma, and a specific subtype of glioblastoma, a genetic subtype where these two patients, two brothers actually, have a germline mutation in a mismatch repair deficiency gene. And these patients ended up with tremendous number of mutations as shown in figure A, much more than other types of brain tumors, as well as when you look at the neoantigens, the new mutations creating proteins that are novel, that are that are foreign. Those neoantigens are even more than melanoma, lung, and colon cancer, which we think is very immunogenic tumors. When these patients were treated with PD-1 inhibitors, as shown on that, you can see before treatment and then 11 days and then 12 weeks, you can see after 11 days, there's tremendous inflammation. And these patients obviously got sick and they had to manage with either steroids or Avastin to control the swelling in the brain. But eventually the patients actually responded, the enhancing tumor shrunk, and patients benefited from this treatment. So again, this highlights that even in glioblastoma, in certain types that have a lot of mutations where they're recognized by the immune system, you can get an immune response to checkpoint inhibitors. But with toxicity, and in this case, they managed the toxicity with Avastin and were able to get the patient through that period and result in a good outcome. So even the mantra is that the blood-brain barrier limits immune trafficking, and that's why we don't get a good response. But there's a study done by Hideo Okada at UCSF. These are his slides actually. In low-grade gliomas, these are gliomas that don't enhance on imaging. That's shown here. You can see this right temporal flare abnormality without any enhancement at baseline. And the patient then received a combination of several peptide vaccine. And during the vaccination process, they did imaging and you can see the T2 increased, the flare increased, suggesting inflammation. In fact, the blood-brain barrier was disrupted with the spotty enhancement shown in that tumor area over time. And then later on, with the enhancement resolved, the T2 was about the same, and the patient didn't have any clinical symptoms during this period. So even though checkpoint inhibitors, the example earlier where there was tremendous inflammation within a short period of time with clinical symptomatology that required treatment, steroids or Avastin. In this case, there was more benign inflammation in terms of not causing seizures or headaches or edema that required management. And so we're just beginning to understand this, what different types of immunotherapies do and how do we understand it and how can we manage the side effect, and balancing that is really critical for us moving forward in the future. So this is the way I think immunotherapy will be in the future, where we will understand the markers better and design better combination checkpoint inhibitors, and with vaccines and oncolytic viruses and other immune approaches. But one of the things that I've always thought about over the years, and that's really hard to do, and John knows this, is try to bring things up front. And I've thought about this for many, many years because I think we set ourselves up in a circle that we never get out of doing trials in the recurrent setting. So most of our trials are really at recurrence, and then we throw away 95% of the drugs, and we just don't seem to be getting anywhere. So our approach is really from the beginning, can we do better in newly diagnosed patients by profiling and using drugs early on in the process, and reiterating and developing better treatments that way. And so that we call this PIN, or precision immunotherapy in the neoadjuvant setting, where we, in the beginning, profile the tumors and understand the tumors and give drugs right away before radiation and chemotherapy, and then look at the response, and then move forward in terms of figuring out why some patients respond and others don't, and then use that information for the next round of combination treatments. And in this initial trial, we've treated 26 patients, and I'm only going to talk about the two arms of Opdivo alone and the Opdivo and Yervoy, which are the checkpoint inhibitors. So to date, we've treated 15 patients in the combination of the Opdivo and Yervoy, or PD-1 and CTLA-4 tumor types. And we so far haven't reached median overall survival, and we're over 16 months right now. In the PD-1 alone arm, it started later, and we're still haven't reached the median overall survival. But these are small numbers of patients. It's only 6 patients in that arm so far. What's interesting is what we're seeing on imaging in these patients. On the top row is one patient for 4 months was on checkpoint inhibitors without requiring radiation or chemo, with the complete response on imaging. And then another 3 months later, a new lesion popped up and we took it out, and the patient started radiation and chemotherapy. The second case is just PD-1 alone, and you can see there was an enhancing lesion post-op that has shrunk slowly over time, and the patient is still responding 9 months going on. And we have a couple of patients almost 2 years out that have not needed radiation or chemotherapy. Most patients, however, do progress and they move on to radiation and chemotherapy. But it's kind of a proof of concept that we can get responders in the neoadjuvant setting. We didn't select patients, so we're trying to figure out what makes these responders special, and can we come up with more combinations to get the response rate even higher in this approach. So this is an approach that we're very dedicated to, that I'd like to spread throughout the Providence Network actually in the near future. We are working with several companies, and I think this is a paradigm shifting approach, and it's going to validate drugs. And I think there are drugs that are active in the recurrent setting that may have value in the upfront, but we never get there because we don't see much activity in the recurrent setting. And we plan to test those drugs through this approach as well. So I just talked about gliomas for the most part, but I do want to give you some examples of other tumor types And I think I only have like about another 10 minutes, so that you can ask questions. But I want to show you these two examples because we're seeing some pretty exciting opportunities here in terms of drugs and combination drugs. So this is chordoma, which is really a bone tumor, but as neuro-oncologists, we treat them because they do affect the nervous system. It's even rarer than gliomas and all the other tumors I mentioned. Most patients have surgery and radiation, but most of them recur. There's really no approved drugs on the market. And this was a patient of mine, a 50-some-year-old patient who has metastatic chordoma. It originally started in the sacrum, but it spread to the brain, multiple brain mets, CSF disease, as well as retroperitoneal and lung tumors. And at the time, again, this shows all the drugs we tried and failed, including immunotherapy. At the time, based on some other data, we thought pemetrexed or Alimta would help. Pemetrexed is an anti-folate drug, like the methotrexate I mentioned earlier for lymphoma. And when we use it at a higher dose than for lung cancer, and this has been published for CNS lymphoma, you can get good brain penetration. So we treated this patient with high-dose pemetrexed. And you can see here, within just 2 cycles, 6 weeks later, the tumors in the brain had a dramatic response, as well as in the body, in the retroperitoneum, and the lung and other lesions that the patient had. So this gave us an idea that we should try this in other patients. And so we did a preclinical study with the Chordoma Foundation screening program, and we could show that pemetrexed inhibited tumor growth in a mouse mouse model of chordoma, and with pemetrexed as well as with combination with temozolomide. So that started a clinical trial. We've enrolled 6 patients to date. The toxicity is expected and manageable, and of the withdrew because of travel during COVID, and they were from Northern California, and 5 patients are on treatment and stable disease. And I'm going to show you this one example of a pretty remarkable response. A 43-year-old woman from Ohio who had a clival chordoma, had a resection 2015, proton beam radiation 2016, came back and had another radiation, and then developed progressive and the right eye in March when I saw her. And this is what the tumor looked like on imaging. And then after 4 cycles of pemetrexed and now 6 cycles, she's had continued shrinkage of the lesion and improvement clinically. This was her visual fields in April before treatment. And you can see on the right eye is completely, essentially blind with the dark. She couldn't see anything out of the right eye. And then after, in July, she was able to start seeing and the visual improvement in the field effect. So I think this is a trial that we're excited, a very small pilot study, since it's only 200 patients in the US. And we're hoping to, once we get enough data, to do a larger multi-center study to try to get this drug approved for this disease. What about meningiomas? As I mentioned, that's the most common tumor type we deal with, although it's very benign. And I'm not going to bore you with the statistics, but although surgically curable, in neuro-oncology, we do deal with disease that tends to come back, or that's atypical, or that's malignant. And so over the years, we've treated patients and looked at the literature of what are the targets, and you can see VEGF, all the same players that we use in gliomas show up: VEGF, PDGF, EGFR, mTOR, but also some hormone receptor, progesterone receptor, and somatostatin receptors. And that's old literature. We've tested all these drugs over the years in these meningiomas, and again, a very small response rate. Single agents tend to do very little, but there are some patients who have remarkable response to these single agent drugs. We decided many years ago that we really should be treating it in a multimodal fashion. So we started treating patients aggressively and as tolerated with the combination of sandostatin, which is targeting the growth hormone receptor pathways, everolimus, which is the mTOR pathway. Hydroxyurea is a known activity. It's a chemotherapy drug. And then mifepristone, which is a progesterone receptor antagonist. And I'll show you some examples. The data is still being developed of patients actually responding to a combination approach. Some patients, like this was a malignant meningioma, before resection, after resection, grew back before we started treatment, and then we saw a partial response with the combination of treatment, including chemotherapy. It really requires multimodal approach in order to treat these complex tumors. But we have this retrospective study, and we want to put together the data that we have in order to support a prospective combination study. And we have some patients on this regimen for over 4 to 5 years now. So I'm going to just end by saying, cancer is complex. Neuro-oncology is even more complex because we have to deal with the blood-brain barrier and issues related to inflammation in the brain. And I think we need to look at cancer from all these angles in order to make a difference in neuro-oncology and use combination treatments and use it early on in the disease process, because later stages of the disease, I don't think we can do very much for. And this is where big data, genomics, informatics, and that data is very important from the beginning of the journey for each patient, for us to make a difference very quickly. And that's why we've focused on a very translational effort of collecting specimens of all sorts and using that information to help us design better clinical trials going forward. So I know I talked a lot and a lot of information in there. I appreciate your time and patience, and I'm happy to take any questions. This is the team that makes it all happen in Southern California, and thank you for your patience.
Thanks, Santosh. That was a terrific review of the targeted approaches that you're championing. I think it's really exciting to see the changes over the last few years in neuro-oncology away from sort of a Gallagher hammer on the watermelon approach to a very thoughtful, targeted approaches. We've got a long way to go, but this work is terrific. So I have a couple questions. NGS, next generation sequencing on, do you do that at the time of diagnosis in your practice, at the time of recurrence, and at those two settings, it doesn't matter where you do it, and at those two settings, how often do you end up using that in day-to-day practice with glioblastoma?
So we do it up front because, as you know, I try to plan very early. I'm going to do tomorrow for each patient, because tomorrow comes around very quickly. Because our patients progress, soon after radiation, a quarter of patients are progressed already. And so we have options and getting off-label drug approvals are take several months. So we do try to profile immediately. The question of if you have a recurrence, whether you should profile the new specimen and how does it relate to the original specimens. We've done one study with Keris as well as other people. And for the most part, when you haven't targeted that mutation, like EGFR, et cetera, most genomic changes, 80% be the same. So I think the information from the original tumor is okay to use for genomic studies or genomic decision-making. So I think it's okay. And obviously the first tissue, you have access and you can profile and have that information available so you can plan for the future. Now, we do focus a lot on clinical trials. So we do have upfront trials and recurrent trials, and that's the first priority. But when we don't have trials is when we use that information to try to help patients.
Okay, thank you for that. We have a question from Bonnie Kung in Neuro-Ophthalmology. A compressive meningioma of the skull base, vision loss if on the optic nerve and if not surgically decompressed. How long does it take for the medications to shrink meningioma? I worry about waiting a few months and the effect on vision.
Well, that's a great question. So whether it's a glioma or meningioma, I think if it's clinically accessible, it should be decompressed because that will help the patient immediately clinically. So in oncology, the faster the tumor grows, the faster it could respond to a treatment that works. So a slower tumor grows, the slower it's going to respond. So meningiomas, if it's causing a compressive problem, with radiation or with any chemotherapy or therapy, won't help clinically. So some of the meningioma data that we have, especially with the progesterone receptor antagonist, there are responses, but it takes years to see the tumor shrink over time. In fact, I have a patient now 8 years out on mifepristone, and now I see the shrinkage after 8 years. Year by year, stable, stable, stable. But now retrospectively, I can go back and see it was actually shrinking for many years. And it's clear that that's what's been happening. So meningiomas responded to the drugs that I mentioned is not a fast response, it's a slow response. The one example I showed was meningioma, and we really hit it hard with various drugs. And we did see an immediate response 1 month later, but that's a unique situation.
We have another comment from one of the participants. Dr. Barsher says, "Thanks, Santosh. Great to see you."
Good to see you.
For the meningiomas that you think might go on Afinitor, do you prove that they have an NF2 mutation before you give them Afinitor?
So the ones. So it's an interesting. We're trying to figure out how to do this as a prospective trial going forward. But for instance, the Korlym is the mifepristone is given to patients who are PR positive, and so we have to find a mutation or a reason to use everolimus in patients. But it doesn't mean that other patients couldn't respond. So, but this is something I'd love to work with you and others on, is look at our data and then come up what is the best plan going forward. Should it be fully genomically informed, or should we just try this combination because we know patients will have a variety of these pathways activated?
Questions?
Great. Thanks, Santosh, for that great talk. My question is regarding the immunotherapy trial. You're giving it up front. Was that preoperative delivery? I know there's some data suggesting a survival benefit if you give it preoperatively. Is that the approach?
So, very good point. Let me just, the term neoadjuvant means something completely different in breast cancer, lung cancer, and brain tumors. And even in brain tumors, the public giving nivolumab preoperatively was in a recurrent glioblastoma setting. And they call that neoadjuvant. So that is very interesting. And we started this study 5-6 years ago before all that data came out. But this is newly diagnosed patients post-operatively that we gave the drugs to. But we have been thinking about how to even potentially give it earlier. It's possible. It's possible. But that's the definition we're using.
On that subject, can you talk a little bit about why immunotherapy might work before radiation and chemo when it clearly doesn't work after?
Yeah. So, very good question. And so, if you yeah, great minds think alike. So actually, if you look in the breast cancer literature, the checkpoint inhibitors in recurrent breast cancers are not very effective. But if you look in the neoadjuvant, more recent literature on trials, so in the recurrent, it's 5% less response, okay? In the neoadjuvant in breast cancer, which is you do a biopsy, make a diagnosis, you give some treatments, and then you do a mastectomy or a bigger surgery. So in that neoadjuvant setting, they see over 35% response rate with checkpoint inhibitors. So So the earlier in the disease process, the better. I mean, you know, after chemotherapy, after radiation, what happens to our immune system, right? We know that many of these patients are lymphopenic. They don't have a strong immune system. Point inhibitors in the setting of no immune system won't help, or a badly torn down immune system won't help. So that's the real rationale for why even in the breast literature, they moved everything and they see a better response. And I think in glioblastoma, that's what we have to do. And it's not just with immunotherapy. I think it's also with targeted therapy and many other therapies. We should be doing clinical trials up front from the beginning.
You know, another thing, and I see Charles Cobbs on the phone. You know, one of the things that can really propel a field is to have a paradigm busting technical development. And I'll tell you what we're missing in neuro-oncology. We need real time. We need same day biopsy in a CT scanner of brain lesions. Patient comes into clinic, they got a bad scan. Getting tissue and figuring out what's going on with the tumor at that point is an overwhelming logistical problem. They've got to go to the OR, they got to be put to sleep, and what, for a biopsy that might or might not help. I think, Charles, if we could simplify brain biopsy, and so I come to you, you know, at 2 o'clock this afternoon, and I say, this scan looks horrible. Can you get me something? We call the CT scanner, you get a biopsy, and at 5 o'clock, you know, we're tidied up, and the next day we get some molecular data. And you know, if we had a simple way of doing brain biopsies, it would revolutionize the field. And I just don't know why we can't pull that off.
Well, it is doable. It's just sort of how far do you want to push it? I mean, when I was a resident at San Francisco General Hospital years and years ago, I would go down to the CT scanner, drill a burr hole, stick a needle in, run them into the scanner, make sure I was in the lesion, take a little bit, pull it out, do another scan, make sure there's no bleed, and then, you know, didn't have to mess around with the frame and all that stuff. I don't think we really want to do that. But, you know, anything's possible to do, and it just depends on, you know, willing to do it, what the risks are, and what technology you have available.
Yeah, I think we do want to do that. Santosh, if you could get same-day brain biopsies based on a bed scan in clinic, would that revolutionize your work in neuro-oncology, do you think, or not?
Absolutely, and that's what it's done for the rest of the cancers with interventional radiology. See anything in the body very easily. So, but the risks are a little different, as Charles mentioned, for the brain and how to do that. And actually, John, we've had conversations about this because I've been thinking about this too. How do we do this so that, you know, patients don't have to stick around for 3 days in the hospital, et cetera. It's something we should think about and talk about and look at what new technologies are out there that we could potentially use to help us.
Charles, aren't there these new laces that attach to the edge of the burr hole or something and help you stabilize the needle as it goes in and hold it there?
Well, Medtronic has a stereotactic biopsy thing, but it's really something you have to do in the OR. You know, you drill a hole, and then you screw in a little thing, and then you angle it, and you use the stealth wand and everything to make sure you're in the right spot. But basically, that's a stereotactic biopsy, and it needs to be done in the OR in 2020. I mean, I was talking about stuff back in the last millennia that was done sort of on the fly.
I mean, I think we need a paradigm buster here, and
possibility of, I mean, patients have circulating DNA in their blood that often will show gene polymorphisms. I'm sure Santosh knows all about that. And there's papers on GBM. You could do a liquid biopsy and PCR up certain SNPs that you're looking for and that kind of thing.
Yep, absolutely.
Well, I think that brings us to the 8:30 hour. I see Dr. Elliott has come on to sweetening
Ringing the
along
bell.
here.
No, this has been such a good, conversation towards the end. And I think the exciting part as well is like this type of conversation and collaboration is what we're hoping more of as we work across the system level with your group, Santosh, to, really bring these high level services to, everybody across Providence. So thank you so much for the wonderful talk.
Great. Thank you, guys.
Yeah.
Thanks so
Thank
much.
you.
Thanks, Santosh.
Thank you.
Thanks for watching. Hit the subscribe button for more medical content.